Okay, everyone, I think in the interest of time, we'll get started because we have our second session running a little bit later. So welcome everybody to the COVID-19 internal medicine refresher. Thank you for persevering with us through the challenges today. Just before we get started, I'm just going to give a quick shout out to the organizers of today's event. So Dr. Arfeen Malik, she's a PGY5 psychiatry at U of T. Dr. Tanzila Basreen, she's a family doctor in North York and an ER physician in Lindsay, Ontario. Dr. Ahmed Faris, PGY3 Public Health and Preventative Medicine at University of Montreal. Dr. Hamzah Qureshi, who you see on the screen, will be presenting right now. He's a PGY4 Internal Medicine at U of T. Dr. Nazia Sharfuddin, she's a PGY4 Internal Medicine at University of Alberta. And then Dr. Sayara Schwetz, hopefully I didn't butcher that completely. She's PGY4 Emergency Medicine at University of Saskatchewan. And I am Dr. Bilal Lone. I work as a sports and exercise medicine physician here in Hamilton. So I'm going to pass the mic over to Hamzah and we'll get started. And then if you have any questions, just feel free to post them in the chat and then I can pass them over to Hamzah. Thanks.
Sorry about that. I was just unmuting myself. Can everyone hear me okay? Okay, I'm going to take that as a yes. So thank you, Bilal, for that introduction. In the interest of time, we're going to get started. And so in terms of conflicts of interest, I have none to declare. Just an FYI, I am a member of the MMAC. And I'd like to also thank the MMAC for taking the time to organize this event in such a short amount of time. We thought about this idea about a week ago, and now it's coming to fruition, and we've gotten a lot of positive feedback, and we hope to get more feedback from you after this session. So let's get started. Just before going into the content, I just want to give a little bit of background information. There's a lot of people here with very diverse set of backgrounds, from family medicine to psychiatry, pediatrics, emergency medicine. There's some even internal medicine subspecialists that are attending this. So Nazia and I had a very difficult time to try to make this basic enough so that, you know, people that haven't had as much experience in acute medicine would benefit, but at the same time be more comprehensive so that people who had that experience would also benefit. So again, we would appreciate feedback at the end of the session, and we'll be happy to hold further sessions if there's interest. If there's more interest in holding a more basic session, we'd be happy to help with that, or a more advanced session, we'd be happy to do that as well. So this is the outline for today, the ABCDEs of internal medicine. So we'll be talking about acute respiratory failure, and within that we'll be talking about heart failure, COPD, asthma, pulmonary embolism, as well as infection. Then we'll be moving on to basics of critical care. And in terms of basics of critical care, we'll be talking about kind of the lingo in critical care, more so focusing on ventilators and pressors. Again, this may be a little bit more advanced for some people. For others, it may be just review. So we're not going to be diving too much into it, and we're going to try to keep it as basic as possible. We'll also spend some time on COVID-19 management. And it is a novel virus, as we all know, and maybe some of you have encountered some of these patients. We'll be talking a little bit about the management of the medical patient with COVID-19, not focusing too much on intensive care management, but we may touch on it a little bit, but that won't be the focus. And then talking a little bit about some nuances and things to look out for in COVID-19. Also talk about delirium, and of course we have to have a talk about electrolytes, because it's not internal medicine if you don't talk about hyponatremia. And then hopefully we'll have about 20 to 30 minutes of question and answers. This session is being recorded, so for those that can't make it or have to leave early, we will send a link out for that. I will also make the slides available. We may make some corrections here and there after the presentation to the slides, and we'll make that available to everyone who was able to or not able to attend. So don't worry about that. Hopefully you can just sit back and listen. So let's start off with acute respiratory failure. So in acute respiratory failure, this is a great table. It kind of outlines the two things I think about. But when I mention acute respiratory failure, I'm really thinking of four things. I'm thinking of shortness of breath or dyspnea. I'm thinking of respiratory distress, so someone who's working very hard to breathe. And then I'm thinking of these two aspects, hypoxemia and hypercapnia. And they're not mutually exclusive. I know we've divided the table as such, but they can coexist. So keep that in mind when you're seeing patients with hypoxemia or hypercapnia. The definitions are there for you to look at. PaO2, which is the partial pressure of oxygen in an artery. So you have to do an ABG to find that out, less than 60. But nowadays we have pulse oximeters, so we can actually look at the oxygen saturation. Typically, we keep the patient's oxygen saturations above 92% in hospital. Anyone that dips below that or dips below 90%, whether on room air or on supplemental oxygen, we start getting worried about worsening hypoxemia or hypoxemic respiratory failure. And the differentials there, the main things I want you to keep in mind are the acute causes of hypoxemic respiratory failure. So heart failure, an infection, so pneumonia, but viral infections can also cause it, a pulmonary embolism, pneumothorax. Now that's uncommon in the internal medicine population, more common in trauma patients, but you have to think about it, especially in the ICU. Pleural effusions. Again, that is usually more insidious in onset as opposed to an acute cause of respiratory failure. So just keep that in mind. And ARDS, which we'll mention in the critical care section. You can see here that MI-ACS is listed, and for the cardiologists out there in the crowd, I do apologize. I don't mean that MI or an NSTEMI or STEMI can cause hypoxemia, but if the patient is in heart failure, that can cause hypoxemia. So an MI leading to heart failure can lead to hypoxemia. If the patient has an isolated MI and is hypoxemic and not in heart failure, you have to really think about what else might be going on. And then hypercapnic respiratory failure is when the PaCO2, which is the partial pressure of carbon dioxide in the artery, is less than 40. And some patients with underlying lung disease, especially COPD or obesity hypoventilation syndrome, which are chronic diseases, will have a PCO2 that is elevated. They may be in the 50s or 60s. I've seen patients in the 80s even. And so that is not the only definition of hypercapnic respiratory failure. It also includes the pH being less than 7.35. I would actually say less than 7.3. So there has to be some acidosis involved with hypercapnic respiratory failure. In terms of the differential for that, it's listed here. Most commonly COPD, asthma exacerbations, patients with brainstem strokes, you have to think about they're hypoventilating. That's when I say hypoventilation, I mean they're not bringing in enough air, and that can cause the CO2 levels to rise. And then muscle weakness, whether that be chronic diseases like ALS or myasthenia gravis, or just patients tiring out. So someone who has heart failure or pneumonia and is working very hard to breathe, and then all of a sudden just, their muscles can't take anymore, they give out, and then they start hypoventilating, which causes the CO2 to rise. As I just, again, want to mention, these are not mutually exclusive. Oftentimes you'll see patients with both. So keep that in mind. This is just, I'm not going to spend a lot of time on this slide. It's just what you may hear on auscultation. Again, these aren't mutually exclusive. When you hear a wheeze, something important to note is it doesn't necessarily indicate asthma or COPD. I've seen heart failure patients and fluid heart failure with a wheeze as well. You have to think of pulmonary edema in that case. And crackles indicates usually some sort of substance filling the alveoli. So you have to think of pulmonary edema. You have to think of infection. And sometimes infections can also cause wheezing, especially viral upper respiratory tract infections can cause wheezing because of patients having may not have asthma, but they may have some just what we call reactive airways. And so just keep that in the back of the mind, because we don't want to just put patients on steroids unnecessarily. So acute heart failure. So I apologize to the cardiologists that may be in attendance if I butcher this. Please do chime in if you have any other thoughts. I've tried to make this basic enough for the people who haven't seen a lot of heart failure to grasp. Really, the symptoms are dyspnea on exertion. Can also be dyspnea with rest, orthopnea. So you want to ask patients how many pillows they sleep with, or can they lie flat? Are they comfortable lying flat? You also want to ask about edema or peripheral leg swelling. Physical exam is listed there. You want to look for the JVP. I know it's sometimes not able or easy to appreciate. And I wouldn't spend 100 hours looking for it. If you see it, great. If it's elevated, great, gives you a little bit more information. If not, move on to the rest of your physical exam. And then you're going to listen to the chest. Usually crackles will be diffuse. Usually, oftentimes will be more basal in nature, but if they're progressing upward into the lung fields, that can also occur. And then bilateral edema of the extremities. The investigations now in internal medicine or ICU, a lot of the times will be referred patients with that have already had a lot of the workup done. So a chest x-ray almost always is done in a patient with heart failure. And that will show things like cardiomegaly. As you can see in this, this heart isn't actually that big, but other times you'll see more marked cardiomegaly. You'll see bilateral opacities. Now that's if they are in frank pulmonary edema or alveolar edema. Other times you won't see the patchy opacities. You may just see interstitial markings, which are our radiologists in the crowd are defined as lines on the x-ray, such as curly B lines. That indicates interstitial edema, which is also a sign of heart failure. And then not listed here, but sometimes you can see bronchial cuffing. And if you see my arrow, I think I see a little bit of bronchial cuffing there, here, here. So that can indicate, can be a sign of heart failure as well. The workup we already mentioned. When I think about any patient with chronic disease that's acutely flaring, whether that be heart failure, COPD, or others, I want to make sure, well, yes, they're in heart failure. That's a syndrome. Why are they in heart failure, and why are they in heart failure now? So again, this is not a comprehensive list of precipitants of heart failure, just kind of important, most common things that you should think about. You should think about cardiac causes of heart failure, meaning are they having an acute cardiac event, such as an NSTEMI, a STEMI, or or ischemia. You have to think about arrhythmias as well. And most commonly, these patients will go into atrial fibrillation with a rapid ventricular response, so fast heart rate, and that will trigger heart failure. And some of these patients will be in heart failure, and that will trigger their arrhythmia. And so sometimes it's not easy to tell, but keep that in the back of your mind. If you see a patient in heart failure and they have a rapid heart rate and they're in atrial fibrillation, is it the atrial fibrillation that caused their heart failure, or is it the other way around? And then other common causes, patients who don't adhere to dietary restrictions. So we recommend dietary salt restriction as well as fluid restriction. So I have a water bottle here. This is 500 milliliters. We restrict usually our chronic heart failure patients to 3 of those a day in 24 hours. So 8 a.m. What I tell patients is 8 a.m. from the today or the day that I talk to them to 8 a.m. the next morning. They should only drink 3 of those water bottles, especially if they have a reduced ejection fraction. But even if they don't, I would say I would try to restrict them. And if they're drinking more than that, so that may be a precipitant of heart failure. Other things include non-compliance with medications. If they're on chronic Lasix therapy, or if they're on an ACE inhibitor or beta blocker and they stop these therapies, that can also precipitate heart failure. The treatment is Lasix, as many of you may be aware. I typically start pretty aggressively, that's what I've been taught by my cardiology colleagues. So I start with, if it's someone that's not known to be on Lasix, so if there's no history of previous heart failure and they've never taken Lasix before, I usually start with 40 milligrams IV BID. If they've been on Lasix before or they're on them currently, I usually take their home dose. So let's say they're on 40 daily. I take that and I make it take that, I divide it into 2 doses and do it BID as well. So 40 is probably not a great example. Sorry, I multiply it by 2, I multiply by 2 and then divide it into 2 doses. So 80 IV BID for someone who's on 40 daily. It's pretty aggressive. And again, we monitor these patients in hospital with daily electrolytes and creatinine, which we should be doing on patients on, especially on IV Lasix. We should monitor their daily weights. And it's helpful to know what their dry weight is. So always ask the patients before in your history what their dry weight may be, and then measure their weights on day 1 and then daily. And then I target, or at least I've been taught to target a diuresis of 2 kilograms per day. Again, this may vary, practice patterns vary. This is just a target. And it really depends on how far they are away from their target weight. And I also, the other thing to mention is to restrict sodium and salt while they're admitted. So in your diet orders, make sure that you're restricting these patients from that perspective. Moving on to COPD management and asthma exacerbation management. So
just
yeah,
interrupt. There's just a question here.
Sure.
So the question is the take home being Lasix multiplied by 2, then give that BID for the acute heart failure management.
Yeah, that's if someone's on chronic Lasix therapy. If they've only taken it once, and maybe my cardiology colleagues that are in attendance can comment on that. Some people will be less aggressive. I think the take home point is you want to start at a higher dose of Lasix when the patient is on chronic Lasix therapy. So if it's 40, I usually, I do it simply, I just multiply by 2. Or sorry, excuse me. Let me just think about this for 1 second. So what I've been taught is actually multiply by 2 and divide it into 2 equal doses and make that IV. Does that answer the question?
Sorry, I had to make myself host again. Yes, I think it does.
Yeah, perfect. Okay, I hope that clarifies it. Perfect. And again, if someone in the participants wants to comment on that, please do. I just want to make sure I'm not confusing everyone. Okay, so moving on to COPD and asthma management. So commonly we'll present with dyspnea, again with exertion, can be at rest. We'll also produce with or present with other symptoms, other respiratory symptoms, particularly cough and sputum production. You want to ask about increasing sputum volume and increasing sputum purulence. Both of those questions you want to ask. You want to ask about wheezing and listen to that as well in your physical exam. In patients with both COPD and heart failure, you want to make sure they're not in significant respiratory distress. So by that, I mean, are they sitting up and tripoding? Are they using their neck, using their abdominal muscles to breathe? These are very important signs to watch out for. So make sure you're really even just inspecting the patient well to make sure they're not going into impending respiratory failure. And on the chest x-ray, actually, a lot of the times I would say the chest x-ray is clear. Sometimes you'll see chronic changes of hyperinflation. That's usually a sign of gas trapping, meaning they just have chronic airways disease. And there may be signs of superimposed infection, so consolidation. And so you have to think about if there's a superimposed pneumonia. Management of these patients, oftentimes with COPD, particularly not asthma, COPD specifically, as I mentioned, that can cause your baseline CO2 level to be elevated. So we say in hospital, you should keep these patients between 88 and 92%. I think initially when a patient is an extremis and is quite ill, you still want to target an O2 sat above 92% first. And then once they start settling down, you can keep them between 88 and 92. So when you admit them, hopefully by that time they've settled down and you can target a SAT between 88 and 92. The management of COPD and asthma exacerbation is very similar. I'll outline the differences, but first talking about the similarities is you're going to bronchodilate these patients. You're going to use inhalers, including Ventolin, 4 to even 8 puffs via an meter dose inhaler. If they're unable to do that, you can use nebulized Ventolin and Atrovent. The one thing I will mention about nebulized Ventolin and Atrovent is, especially now with COVID going around and not knowing if the patient is positive for COVID right away, especially in an emergency department setting, I would avoid nebulized masks, and we will talk about that a little bit in the COVID management, but try to avoid nebulized masks. And I think the hospitals are putting in protocols to avoid that right now. I would just go to the meter dose inhaler. Most patients are able to do it themselves. If not, the nurses can help with that. And again, 4 to 8, this says 4 puffs. I go big. I go eight puffs initially, especially if they're an extremist, and then you can dial back to 4 puffs. You can do it as frequently as needed. I usually, for my COPD patients, will do every 4 hours. If they need it more frequently than that, then I have to consider whether they should be in an ICU setting. Same with asthma. Asthma, you can actually do it more frequently initially. You can do it every 15 to 20 minutes for the first hour, and then dial back to maybe every hour and then every 4 hours. Again, it depends on the clinical situation. If the patient's an extremist, I usually do it more frequently. And then you treat them with steroids. And so prednisone 40 milligrams is the usual dose for both COPD and asthma. You don't need to go higher. There's, if you don't think they can tolerate oral, whether they're vomiting or can't swallow or whatever it may be, you can use IV methylprednisolone. This dose is quite high. It's 125. That's actually very high. Methylprednisolone alone itself, dosing is higher than prednisone. So it's actually 40 milligrams of methylprednisolone is 50 milligrams of prednisone. That's the conversion approximately. So I would just use 40 milligrams of methylprednisolone in a COPD asthma exacerbation. This obviously isn't necessarily for patients with status asthmaticus, which is a very severe reaction or asthma exacerbation, which we're not going to really touch on right now. They may require higher doses of steroids, but there's no real evidence, I don't believe so, for that benefit. But again, we're not going to touch on that. You have to, again, remember why did they go into COPD, especially for COPD and asthma exacerbations. Why did they all of a sudden just exacerbate their underlying lung disease? So you got to think of whether there was a trigger, environmental trigger. Are they still smoking? Are they adherent to their inhalers? Or is there a superimposed infection? Now, again, this is a little bit of commentary given the COVID-19 situation. Because it's community spread, I would be very, even if they haven't had travel history or contact with anyone with COVID or whatever it may be, I think we just have to keep in the back of our minds, is this a viral exacerbation? And so we have to take the proper PPE protocols and obviously testing for these patients. I would have an extremely low threshold. Actually, I think if someone comes in with a COPD asthma exacerbation to hospital and they're from the community, I would test them for COVID. I think anyone would. But not just that, I would also treat them in terms of isolation protocols as COVID until proven otherwise. And that's why I would avoid nebulization, and I would also avoid NIV in those situations. And we'll talk about non-invasive ventilation in a second. And again, you want to watch out for respiratory failure. The one thing in COPD management that I will mention is you can also start patients on antibiotics. I typically start patients on antibiotics if they have the following: increasing sputum purulence, increasing sputum volume, both of those, and either a white count or a consolidation on chest x-ray. If they have one isolated, like if, for example, they only have increasing sputum purulence and nothing else, I may decide to not give them antibiotics and see how they do. And if they don't get better, then add antibiotics. If I find they have all of them, I typically that's a pretty good indication for antibiotics and COPD exacerbation, especially if they have a consolidation. I typically always treat those patients with antibiotics. But if they have, in the absence of a consolidation, in the absence of an elevated white count, in the absence of fevers or increasing sputum purulence, I usually don't necessarily treat them with antibiotics and see how they progress. And if they get worse, you can always add antibiotics. The antibiotics of choice I listed here: ceftriaxone and zithromycin. That's kind of your typical pneumonia treatment. I usually just give these patients amoxiclav. Some people can use moxi and levofloxacin. I've been trained by the infectious disease specialist to try to avoid fluoroquinolones, so I usually just use amoxiclav. And this, oh, it's not changing. Okay, so, oh, I think no, that's fine. So just moving on to pulmonary embolism. Again, I'm not gonna spend too much time on talking about PEs, but it's always on the differential when someone has either chest pain or dyspnea. So you have to think about that, especially when they have hypoxemia and the absence of any other concerning findings like heart failure or COPD. And then obviously you got to think about the risk factors for someone who might develop a pulmonary embolism or a venous thromboembolism. You got to think of recent immobilizations, trauma, surgeries. You got to think of malignancy. If the patient has an underlying cancer, that puts them at a higher risk. We did put a little bit of the Wells criteria there to define whether it's low risk, intermediate, high. Some people just use low versus high risk. And if they're low risk for a PE or a venous thromboembolism, then you can just do a D-dimer. If the D-dimer is negative, then that's a very good test for a low probability patient to rule out a venous thromboembolism. Whether that be DVT or a PE. If it's high, then you have to consider, if your pretest probability is moderate, then I would go on to doing a CT pulmonary angiogram. If there's any hematologists in the group, they can please comment on their thoughts as well. And usually I go to CT pulmonary angiogram. A VQ scan is actually a good test for a pulmonary embolism as well. The only problem is with a VQ scan is usually you have to have a normal chest x-ray for it to be a reliable test. And if you don't, then the VQ scan may not be reliable and oftentimes will be inconclusive, and therefore you just have to do a CT pulmonary angiogram anyways. We listed the treatment here: IV heparin, low molecular weight heparin, or a DOAC. So you want to anticoagulate these patients because they have a clot. I typically see patients who are fairly stable with pulmonary embolisms. Oftentimes they don't even require hospitalization. There are clinical decision criteria to decide who needs admission and who doesn't. Oftentimes these patients can be treated from home as outpatients. So in that case, I usually, especially in the absence of malignancy, I'd use a direct oral anticoagulant. So apixaban or rivaroxaban, edoxaban, or dabigatran. I typically use apixaban in these patients. I like that anticoagulant. The one thing I would note is for DOACs is if you're going to start them on that a DOAC, you need to load them with a higher dose initially. So for my example that I used was apixaban. You have to start them at 10 milligrams twice a day for 7 days, and then drop them down to 5 milligrams twice a day for the duration of the treatment. If it's a provoked event, meaning they had a clear provoking factor, surgery, trauma, something like that, then you treat them for a time-limited duration of 3 months. If it's unprovoked, then usually these patients will require lifelong anticoagulants. That's a decision I would actually refer these patients to thrombosis at that point to make that decision on whether they require lifelong anticoagulation or not. Usually that is the case. But that being said, they only need the full dose anticoagulation for about 6 to 12 months, and then they can drop down to a lower dose anticoagulant. Again, my hematology friends in the crowd can comment on that if I'm making any mistakes. And again, that's a decision that's a long-term decision, not an acute decision. You just need to start these patients on anticoagulation and then refer appropriately. Going on to pulmonary infections. So in terms of...
interrupt. Sorry,
yeah.
there's a question here.
Yeah.
when do you transition somebody from IV heparin to a DOAC?
So why was high IV heparin started in the first place? That's the question I would ask. Sorry, I should have talked about a little bit of this a bit more. So maybe I'll comment on that and the question. So IV heparin, I usually don't start IV heparin unless they're going to the ICU. That's only because you can turn on and off the heparin quickly and it lasts about 4 hours. Other than that, I don't usually start it. I think I've started on one patient with a PE because they were going to the ICU. But other than that, I just go to a DOAC or low molecular weight heparin. That's a great question in terms of when to transition from IV heparin to DOAC. I would actually ask if my hematology colleagues can weigh in. What I would do is the DOAC is supposed to act pretty immediately. So I would stop the heparin, and it should be out of the system in 4 hours. So I hope that answers that question. Yes, no? Okay. Just one other point I forgot to mention is hemodynamic unstable patients with pulmonary embolism. There should be a consideration for thrombolytic therapy, so TPA. That should be a decision made with ICU and possibly hematology, depending on how sick the patient is and how urgently they may need thrombolysis. Again, you have to keep in mind they don't have any other contraindications to thrombolysis, things like previous or recent stroke, recent significant surgery, and so forth. So there's a list of contraindications to thrombolysis. You can look that up, but again, hopefully you don't see these cases, but if you do, that's a decision that it should be made, especially if it's life-threatening and hemodynamically significant. And by what I mean by hemodynamically significant, I mean they're hypotensive, but they're sustained hypotension despite other resuscitative measures. So in that case, they probably deserve TPA. I've never had to give TPA yet, and hopefully I won't ever have to, but you may have to consider it in certain situations. So moving on to acute pulmonary infections. So really when we talk about acute pulmonary infections, we're talking about pneumonia and pneumonia, and we classify pneumonias into community-acquired pneumonia, which means basically someone coming into the emergency department found to have a cough and sputum and a consolidation on chest x-ray. That was what we call community-acquired pneumonia. Pneumonia from someone in hospital, we've called it healthcare associated pneumonia or healthcare acquired pneumonia. Actually, this definition is now coming out of favor, especially amongst the infectious diseases community. I believe the IDSA has actually taken it off their recent guidelines. So just keep in mind that patients with hospital-acquired pneumonia may have, or patients from a certain setting may have different microbiology causing their pneumonia than someone with a community-acquired pneumonia. When we think about community-acquired pneumonia, again, the symptoms are productive cough, fevers, dyspnea, chest pain. They'll have focal consolidation on their chest x-ray. Their white count should be elevated, and they may have a neutrophilia with that. They may be in sepsis, which we'll talk about in detail in a bit, but in terms of sepsis, you're looking for other end organ damage. And the management for community-acquired pneumonia is ceftriaxone and azithromycin. Again, this will vary a little bit from jurisdiction to jurisdiction. Some places, I'll always use ceftriaxone alone. I only add azithromycin if I feel that the patient's quite sick. There is data to show that ceftriaxone and azithromycin in patients that are going to the ICU is more beneficial than monotherapy with ceftriaxone. So that's what my practice has been typically, to give them monotherapy ceftriaxone for patients who are less sick, and patients who are very sick usually get both. For healthcare associated pneumonia, again, it's going to be on a case-by-case basis. Sometimes you will use ceftriaxone. Other times, if the patient's sick enough, you'll just go to piptazo because it covers more broadly. Just remember that going back to just a little bit of the coverage, again, this is not a talk about what's antibiotics cover what, and if that's a topic of interest, we can cover it at another time. But pip/tazo covers all your gram positives, all your gram negatives, and anaerobes. Ceftriaxone covers the same, I mean, maybe not as great gram positive coverage, but generally speaking, it's pretty good gram positive, covers the same gram negative coverage with the exception of Pseudomonas. So if you have a high suspicion of Pseudomonas infection, which means risk factors of previous Pseudomonas infection, were they on a ventilator, if they were intubated, have they been in hospital for a very long time, et cetera, or previous Pseudomonas colonization from previous sputum cultures, then I would treat them with pip/tazo in that case, or consider treating with pip/tazo. Other than that, pip/tazo doesn't really add much. Again, enterococcal coverage as well, which isn't a bug that causes pneumonia. So really it doesn't add much unless you're really concerned about Pseudomonas. So if you have someone with pneumonia, community acquired, coming in that's very sick, people get put on pip/tazo, but that might not necessarily add much coverage. So I just saw a question, can you speak to the utility of sputum culture? I was actually just about to say that when I said sputum cultures. So yes, I order sputum cultures on all my patients. I usually, I think they're quite useful. I don't know why we don't do them more. They're hard to sometimes be positive. A lot of the times you'll get sputum culture and it'll just be like mixed oral flora, but sometimes you'll get sputum cultures and they show, you know, a bug, and that can be very useful. So I would always get sputum cultures, and we'll talk about sepsis in general. I culture everything, urine, blood, sputum. So we'll mention that. All these patients should also get MP swabs. And again, if someone's coming in with a viral, even if it's not a viral infection, even if it's clear-cut pneumonia in the emerge, everyone should get an MP swab for COVID-19. There may be superimposed bacterial infection, we don't know, so we just swab these patients for everything. For viral pneumonias, I mean, typically they won't have any chest x-ray findings. They can have some chest x-ray abnormalities. As we've seen with COVID-19, there are significant chest x-ray abnormalities. Even with influenza, I've seen interstitial changes. So I would keep that in mind. I wouldn't just say if they have a normal chest x-ray, that's definitely, or if they have an abnormal chest x-ray, that definitely means it's not viral. And again, patients can have both viral and superimposed bacterial pneumonias. They'll get swabbed, hopefully, for the viruses. And if they are clearly viral in etiology, we can stop antibiotics. And usually you only use Tamiflu, oseltamivir, for patients who have confirmed influenza infection. Obviously, we won't know at first, so you empirically cover very little harm in using Tamiflu. But if the influenza swab is negative, I would just stop it because it's not doing anything. And we'll talk about Tamiflu in the use of COVID, but just as an out of interest, it doesn't do anything for COVID, and that has to do with the mechanism of how Tamiflu works. And this was the slide I was looking for after I talked about COPD and heart failure, is non-invasive ventilation. So non-invasive ventilation, or BIPAP. So unfortunately, we should have actually included maybe a slide of what BIPAP is. BIPAP stands for bi-level positive airway pressure. Many of you may have heard of CPAP, which is continuous positive airway pressure. BiPAP is different in the sense that it provides an inspiratory pressure that is different from the expiratory pressure. A CPAP is just a constant pressure that will always be blowing through the mask into the patient. So for BiPAP, the settings are fairly straightforward. There's an inspiratory positive airway pressure called the IPAP. There's an expiratory positive airway pressure called the EPAP. And then there's the resp rate and the FiO2, which is the amount of oxygen you can feed into the machine. There's specific indications for BiPAP, so you should not be slapping everyone onto BiPAP. There's also contraindications to BiPAP. The two big indications for BiPAP are hypoxemic respiratory failure. I wouldn't even say necessarily hypoxemic respiratory failure. I would just say respiratory failure from cardiogenic pulmonary edema, so someone in heart failure, you can put them on BIPAP if you are concerned that they are progressing to significant respiratory failure requiring intubation. But before going intubation, you can trial BIPAP to see if that will improve their outcome. And the data has shown that these patients does reduce the risk of intubation in that population. And then the other indication is COPD exacerbation. Again, this criteria is something I would keep in mind. If you have a COPDer, their pH is okay, their CO2 isn't that bad, and they're having a mild exacerbation, don't put them on BiPAP. But if they're having a severe exacerbation or an extremis and they meet this criteria where there may be some acidosis or acidemia and their CO2 is elevated, then you can trial BiPAP. And you don't have to necessarily admit them to the ICU and have them on BiPAP for a very long time. You can try BiPAP for like 3 to 4 hours in the emerge, take them off, see, repeat blood gas to see how they're doing, and then admit them to the medical ward. The other indication I have here, this is more of kind of just for interest, is pneumonia and the immunocompromised, not pneumonia in general, just pneumonia and the immunocompromised. There is some data that shows these patients benefit from BiPAP therapy and reduce the risks of intubation. It's not as definitive as heart failure or COPD. But you should not be doing BiPAP on patients who have run-of-the-mill pneumonia. And so just keep that in mind. And again, we'll talk about this in COVID. Do not use BiPAP if you have any suspicion of COVID. There is risk of aerosolization. We'll come back to that point, and I'll probably just repeat it then as well. But do not do that because there is risk of aerosolization. And so we are trying to avoid, and I think many hospitals are very aggressive about not doing BiPAP, even if there might be an indication. And that's a debate for the hospital and intensivists and medicine doctors to have. But just beware of that. There are contraindications. Some of them are obvious. Upper airway obstruction, you're not going to put someone on positive airway pressure if they have an obstruction in their airway. They have to be able to cooperate. If someone's ripping off their mask, what happens a lot, especially when they're in acute respiratory failure and they may be agitated, they can't tolerate it. That's something to keep in mind. You can't have patients who are high risk of aspiration or have a full stomach. You have to be careful in those patients because it can cause aspiration because you're providing a positive pressure into the chest wall cavity and can increase the risk of aspiration. They have to be able to protect their airway. They have to have a decent level of consciousness for that as well. I would not put someone on BiPAP who's hemodynamically unstable and obviously who's bleeding. I'm not sure what happened. Yeah. Sorry about that, guys. These are just some indicators of success in NIV. Again, if someone is failing NIV, that's an indication to obviously intubate the patient. And again, those are the patients with heart failure or COPD specifically. Again, shouldn't slap anyone on BiPAP. Just keep that in mind, especially nowadays with COVID going around. So ARDS, acute respiratory failure and acute respiratory distress syndrome. So what is this entity and why is it so worrisome and dangerous? So ARDS is really an inflammatory reaction happening in the lungs due to some insults causing severe hypoxemia. So just very briefly about the pathophysiology. It's not very well understood, but the understanding is there's some insults causing a huge inflammatory cytokine storm leading to leaky vessels, causing non-cardiogenic pulmonary edema. And so when this was first found or first discovered, there was the Berlin definition, which consists of 4 criteria, including an acute onset of an insult. So they have to have something. Sorry, I'm just reading a question. Yeah, I think I mentioned not to use BiPAP for NIV for COVID. For sure, not for COVID. 100% agree with that. There are situations I've heard of other hospitals where the patient may not be, I mean, when someone comes in with COPD or CHF of unclear etiology, they usually get swabbed for things. If those patients are very low risk for COVID, there are some hospitals that are still doing BIPAP. That I'm not going to comment on that specifically. That's their decision and the individual clinician's decision. But for sure, for COVID, no BIPAP. Okay, so coming back to ARDS, so it's an acute onset of an insult. So they have to have something that precipitated the ARDS, and I've listed the insults here, insults or causes. So most commonly are pneumonia, whether it be bacterial or viral. And as we can see, a viral infection, COVID-19 is causing ARDS or an ARDS-like picture. Aspiration, someone who aspirates can go into fulminant ARDS. Someone with trauma, and our surgeons may see this more than myself when they have their trauma patients in the ICU and then they go into respiratory failure because of the ARDS. And then pancreatitis, again, surgery colleagues have seen this many times probably, where patients have pancreatitis, they're doing fine, and then they just go into fulminant respiratory failure from ARDS. And then sepsis and septic shock or shock in general, again, can cause ARDS. So going back to the definition, you have to have bilateral airspace opacities on imaging, whether it be chest X-ray or CT scan. There has to be no evidence of cardiogenic pulmonary edema. And by no evidence, I mean, it can't be alone, the cardiogenic pulmonary edema alone itself can explain the degree of hypoxemia. So they can have some element of heart failure, but that in and of itself can explain the hypoxemia, and that's when they meet the criteria for ARDS. And they have to have moderate to severe hypoxemia. And you'll hear this for those who get pulled onto ICU or have to work in the ICU. You'll hear this PF ratio. And what is the PF ratio? The PF ratio is the ratio of partial pressure of the oxygen, so the PaO2 that I mentioned earlier in hypoxemic respiratory failure, divided by the fraction of inspired oxygen. So that's the FiO2. So when we're out and about breathing room air, that's 21%. Someone who's intubated, you can vary the percentage of oxygen you deliver. If you have someone with someone who's intubated, you can put the oxygen. So the FiO2 is the fraction. It's actually a, it would be, so if you're on 100%, you divide by 1. If you are on 50%, you divide by 0.5, et cetera, et cetera. So they have to be intubated for you to calculate a true PF ratio for it to be meaningful. And they have to be provided with some positive pressure, which we call PEEP, and I'll get into that into the ventilator basics. And the PF ratio being less than 300 but greater than 200 is considered mild. Someone between 100 and 200 is considered moderate, and someone less than 100 is considered severe. And that has implications in mortality, as well as how the intensivist will manage the patient in terms of certain procedures and certain management strategies. The treatment for ARDS is largely supportive. So with mechanical ventilation. So these patients have to be intubated and have to be intubated and managed accordingly. Sorry, I'm just seeing a question, sputum induction. Yeah, I would not induce a sputum to get cultures if that's what people are wondering. If they can produce sputum, that's fine. Do not induce patients with suspected, especially if you're suspecting COVID, do not do that. It's a risk of aerosolization. And we'll get into that into the talk when we talk about COVID. Okay, so this is a chest X-ray, just out of interest to show what ARDS might look like on a chest X-ray. As you know, everything that's white should be black, and that's really a pretty bad sign. And you can see why these patients will become so hypoxemic, requiring intubation and mechanical ventilation. So ventilator basics, just give me 1 second while I rehydrate myself. So Again, we're going to try to keep this as basic as possible, more so as a refresher for those who have already done a bit of ICU. For those who haven't done any ICU, this is a chance for you to learn a little bit of the lingo, and language that they use in ICU. So hopefully, I hope this will be better for everyone, because I know there's people from all types of backgrounds here. So really, I want to keep this very basic for vent settings. There are three main modes. Now, that doesn't mean there's only three modes of ventilation that exist out there. There are lots of ventilator settings and ventilator modes that I'm not qualified to even speak about. But the three modes that everyone should be aware of if they're going into the ICU are pressure control, pressure control, volume control, and pressure support. Those are the three main ones. You'll see 95 to 99% of the patients will be on that, one of these settings. Pressure control and volume control. What do I mean by when I say that? I'm saying that the ventilator is providing a constant pressure in pressure control, or in volume control, they're providing a constant volume of air that's going into the patient. Remember, this is positive pressure. So the ventilator is providing a constant. It will always provide that. That doesn't necessarily mean the patient is not breathing. It just means the patients do breathe above the vent on control modes. So keep that in the back of your mind. But the ventilator is what we say doing the work. It is providing what we mean by that is providing constant volume or pressure. Pressure support is a support mode, which is the ventilator is helping the patient breathe on their own. So the patient may be taking a breath. If the ventilator sees that it's not an adequate breath, it's not reaching that threshold pressure that the ventilator is set to provide, the ventilator will add an additional pressure support, and that's why it's called pressure support. There's not volume support, it's just pressure support. So those are the three modes of ventilation. Are there any questions regarding that specifically before I move on to the settings on the ventilator? What is the role of AC ventilation? Assist control ventilation, is that what you're referring to? So I haven't seen assist control used too much. I believe it's a control method of ventilation. Again, if there's any, I don't think there's anyone in ICU on this talk, but if they can chime in. These are the three main modes of ventilation that I've seen used. Sometimes you'll hear AC, PC, VC. I think those are just control methods of ventilation, to be honest. When do you use pressure support versus volume control versus, okay. That's a good question. Generally speaking, when the patient is acutely unwell and being initially ventilated, you will put them on a control mode of ventilation. So someone crashing on the floor that goes to the ICU and gets intubated will be put on a control method, whether it's pressure control and volume control. Now, when to use pressure versus volume control, there's actually no good answer to that. I've seen both used. There's no reasoning to use one or the other. It's really personal preference for the intensivist. But just know that if you're using volume control, the volume is constant, and if you're using pressure control, the pressure is constant. But there's no difference in using volume control or pressure control in any situation. Pressure support is used when you're weaning a patient off the ventilator. So you don't usually go to pressure support when someone's initially intubated. You'll go to a control mode. And then as you start weaning down the settings, you'll start weaning them to a support mode of ventilation. But you're not going to ever put someone who initially gets intubated on a support mode. I hope that answers that question. Okay, so I just wanted to make sure that everyone's on the same page for that. So in terms of the settings, there's lots of settings on a ventilator, and that's what makes this somewhat complicated even for medicine and residents rotating through ICU. There's rest rate, there's the IE ratio, there's inspiratory and expiratory times, there's PEEP and plateau pressures. really, I need you to know really three things. You need to know the pressure and the volume, which is going to be set, which is what you're setting when you, or the RT is setting when they put the patient on the control mode. So that will be a fixed value. And then the other value, so if the pressure is constant, let's say you're doing pressure control, put them on pressure control, you are providing a pressure of 18 millimeters of mercury. The volume will be calculated. So you'll find out what the volume is from the ventilator. And so you'll have that value, and vice versa. If you have volume control, you're providing, let's say 300 cc's of volume every breath, the pressure will be calculated by the ventilator. And so you'll know those values. So those are the two values, pressure and volume, that you need to know. A PEEP, which is the positive end expiratory pressure. I'll talk about that in a second. And the FiO2, which I talked about, which is the fraction of inspired oxygen. The PEEP is the positive, as I mentioned, the positive end expiratory pressure. What that is the pressure at the end of expiration that is needed to keep the alveoli open. So when we're breathing naturally, we have a PEEP in our bodies. The alveoli don't just collapse completely; they're open to some degree. And so, to mimic that, the ventilator provides this end expiratory pressure to keep the alveoli open, so that you don't get these alveoli that are just collapsing. This leads, when you provide a higher PEEP, this will lead to more what we call recruitment, which means more alveoli are opening up. They're not as collapsed. And that leads to better gas exchange. It also leads to more surface area of lung available for gas exchange. And that in turn leads to better oxygenation. And that's important to know. So if your patient is deteriorating on a ventilator, then you could consider going up on the PEEP. Just be mindful that PEEP can cause hemodynamic issues. Whenever you intubate a patient and put them on positive pressure, you are changing the hemodynamics, in the sense that when you provide positive airway pressure in the chest cavity, you will cause hypotension. And higher PEEPs means higher pressures, which means more hypotension. So just keep that in mind. And obviously, when you provide positive pressure, you are going to possibly cause barotrauma. And so if you keep going up on pressures, eventually you will cause you could cause a pneumothorax. So just be mindful of those situations. In terms of the FiO2, what I mentioned is the fraction of inspired oxygenation. And that is a percentage. So it ranges from 20%, which is room air, 21% room air, to 100%. And again, when you increase the FiO2, you in turn will improve oxygenation. But remember that oxygenation hyperoxygenation has shown in many studies to be detrimental. So we try not to hyperoxygenate our patients. We try to keep them just above 92% and try to minimize the amount of FiO2 that they receive. Obviously, if they're an extremist, they need intubation, they get put on an FiO2 of 100%, and then the RTs will wean them down. So I just saw a question: with the management of hypotension induced secondary to increased PEEP, what is your approach? That is a very good question. And it's a case-by-case basis. So oftentimes patients that are hypovolemic, if you give them a positive airway pressure, you will worsen hypotension. So sometimes they just need a little bit more volume. Other times they'll have other causes of the hypotension. So I wouldn't just chalk it up to increased positive airway pressures, but you have to keep that in mind. Sometimes you need to go up on pressures and their hemodynamics will be compromised. In that case, they should be probably put on vasopressor support. Oftentimes these patients are also sedated, which also drops the blood pressure, complicating matters. And so oftentimes, just because of the positive pressure and the fact that they are being sedated, will drop their blood pressure, requiring you to support them from a hemodynamic perspective. I just saw another question saying, is SpO2 an effective way of monitoring oxygenation versus an ABG? So the oxygen saturation is what they typically use to monitor patients with for hypoxemia. That being said, the ABGs are useful in the ICU setting, especially because they allow us to calculate a PF ratio. But excuse me, I'm just sorry, I just saw a few questions, so I got distracted, excuse me. So for PF ratio, you need to know what the oxygen level is in the artery, and so that's why we do ABGs. And so you can do both, but if the patient's saturating well or saturating adequately, you don't need to do an ABG to check it. It's just to help calculate PF ratios. Someone mentioned how to calculate volume pressure on the vent. The vent will do it. Don't worry about it. It will show the values. And then higher pressures and volumes improve ventilation. So that's CO2 clearance, meaning hypercapnia. So if you have someone with hypercapnia on the vent, you may increase their volumes or pressure. You have to be very careful. I don't do this ever. I just suggest that to the RT. They're the ones that actually do this, and they actually do it without you even knowing half the time. And that improves the CO2 clearance. You just have to be mindful that high pressures and volumes can cause barotrauma, as well as hemodynamic issues that I mentioned before. So there was a question about mention typical starter settings for volume control, pressure support. I've been most experienced in using pressure control ventilation. So providing pressure, constant pressure, and then the volume is variable. The RTs, again, at most of the hospitals, you will have RT support. They're the ones that actually fiddle around with the settings. The important thing to know is these values, and if they change, why are they changing? For example, why did the RT have to go up to the NFiO2 from 40% to 80% because of hypoxemia? Or why did the RT have to go up on the pressure and a pressure support or pressure control setting? Why did that happen? And as the physician, we have to think about these causes, and we'll get into that a little bit in ventilator deterioration. We have to think about what are the causes for that. You don't have to typically set the settings. The RT will do it. Usually they start high. So when someone gets intubated, they'll be started on like a PEEP of 8 to 10, which is a moderate amount of PEEP, sometimes 12. And the pressure may be, 18 to 20 for pressure control. Again, these are rough numbers. I don't, again, do this often. The RT is doing it, and the FiO2, they usually just crank up to 100 and then dial back. And then again, they start high because the patient's an extremist, they're acutely unwell, they need to maintain their oxygen saturation. And once you get them to an adequate oxygen saturation, then you can start dialing back some of these settings. So I hope that answers some of those questions.
Hey, this is Hassan here. I cover GIM, cardiology, and ICU. Just to clarify a little bit, thank you so much first and foremost for a fantastic talk. In terms of the vent settings, just to clarify, so pressure control is a setting that is typically put on right at the get-go, typically when the patients are quite sedated and not initiating their own breath. And so what the vent is doing is that it's going to initiate the breathing for the patient at the time. Over the course of and that's typically what most of us are going to be putting all of our patients on in collaboration with the RT, as Hamzah said. The RTs are very important in helping us decide what to do, but the usual thing is when patients require intubation, they'll get put on pressure control. As they're improving and hopefully they're initiating their own breath as we wean sedation, then one can transition to pressure support or the assisted control ventilation. The pressure support means that they're able to initiate all of their breathing independently. They're initiating their breaths independently. Assisted control is a situation where it's more of a volume setting. And so what'll happen is that the patient is hopefully trying to make their own breath. And it's a means of weaning. So let's say if they don't hit the tidal volume that you're attempting to hit, then there will be assist either in the number of breaths or in terms of the pressure that's provided to ensure there's an adequate tidal volume or adequate amount of oxygen that's given to the patient. And that's a good method to try and recruit some of the respiratory muscles that may have weakened due to a long duration of intubation. But typically, Common things being common, the patient gets intubated. Initially, everybody gets put on pressure control. Over time, as they wake up and are able to initiate their own breath, they'll either go on an assist control or they'll go on pressure support. And then there's plans for weaning. But as Hamzah has said, these decisions are made with the ICU staff, and especially with the respiratory therapist, who will initially set up basic settings of inspiratory pressure, PEEP, FiO2, etc., and adjust them accordingly based on your PaO2, which is based on ART line. Most vented patients should have an ART line that allows you to manage Q6 or Q12 ABGs to assess their PO2 and adjust the vent settings accordingly. And again, the RT and the ICU physician can certainly work with the team. It's not like you're going to hopefully ever be left alone to manage vents. Obviously, people have to go through long periods of training, whether it's through ICU or cardiology or what have you, anesthesia, respiratory medicine. So just wanted to chime that in based on the different ventilation settings.
Perfect. Thank you, Hassan, for that. Yeah, and I just wanted to read, someone mentioned with a lot more experience than me probably, the current vent settings are assisted control rather than, just reading it, rather than control. The difference is in control modes, you eliminate the patient's ability to trigger the vent. In assist control, the vent will give the patient a minimum rest rate, which Hassan mentioned. So thank you, Hassan, for adding that. That's very helpful. Like I said, I should have prefaced this that we're trying to make this very basic. A lot of you won't be in ICU, hopefully. And those that all are called on to ICU, you'll be working with an intensivist and RTs and other fellows and in critical care, cardiology, respiratory medicine, whatever it may be, or internal medicine. So you won't have to, and you won't be changing these settings yourself. The RTs do it, but themselves, there's protocols to do this, and they will let you know about, okay, what did these settings go awry and what happens in those situations. And our purpose is to just get the basic lingo down so that if you're put in this environment, you know what they're talking about. And I hope that clarifies some of the questions going forward. So just back, I mentioned this, higher pressures and volumes improve ventilation. But again, you got to be careful. You don't want to cause barotrauma as well as other hemodynamic issues. So ARDS management, and this is very basic ARDS management. Again, as we've mentioned, you probably won't, someone just asked about barotrauma. I'll come to that in 1 second, just after I talk about ARDS. So again, you're not going to be left alone to manage these patients. And as I said, the management of ARDS is largely supportive with mechanical ventilation and what we call lung protective ventilation. And what do we mean by lung protective ventilation? We're talking about low tidal volumes. So those are between 6 and 8 cc's per kilogram. There's always this talk of permissive hypercapnia. When we say permissive hypercapnia, we mean if the CO2 goes up, we don't freak out necessarily as long as they're not acidemic or acidotic. So we want to keep the pH between 7.3, 7.4. There's a high PEEP strategy that's used for ARDS management, and they use a PEEP plus FiO2 table to titrate. And they use something called the ARDS net or the ARDS net protocol. Many ICUs are doing this, and that's how they manage these patients. So there's a standardized protocols that the RTs, the intensivists, they all use. So again, you won't be doing hopefully any of this on your own. Again, and if you're on the ICU side or helping out with the ICU, you will have supports definitely in that situation. And then you have to consider, just again, this is just for information purposes, consider proning if the PF ratio is less than 150 despite the above measures. And what by proning I mean is normally, in hospital, all of us are lying in bed. Hopefully some of us are, I shouldn't say us, I should say patients are lying in bed. And their back is on they're lying on their back. And so in the ICU, especially in ARDS patients, what they may do is consider flipping the patient onto their stomach, called proning. and that has shown to improve oxygenation in patients with very severe ARDS. That has to do with the pathophysiology of the disease, as well as the amount of lung that's quote unquote recruitable that you're lying on, and it has to do with the mechanics of it. So I'm not going to dive into proning. It's just of note that that is a management strategy. And ECMO, I'm not going to talk about at all. It's a salvage therapy. And just out of interest, it is when blood is removed from the body, put through an oxygenator, excuse me, CO2 is removed and then brought back into the body. That is only done at super hyper specialized centers. And right now, I think in Toronto, the only center that does it is Toronto General. But again, that's salvage. It's not really something we'll see, hopefully. So just to comment on the barotrauma, and so yes, Hassan mentioned only centers with experience for prone. Yeah, I was just mentioning that proning, again, none of us should be doing this on our own. Only centers that have the capacity, the capabilities to prone patients should be doing this. And again, if you're in the ICU at a large hospital, you'll be probably seeing these patients. But again, this is just for interest's sake more than what you would be doing individually as a resident or a physician managing patients. So what to do when you have someone on the ventilator and they deteriorate? What do you do? That's scary. So relax and stay calm. Get a stat chest x-ray, do an ABG or VBG to see what their blood gas is doing, to see if they're becoming hypercapnic or and so forth, and what's the pH doing. And then basic steps to do. You want to make sure everything's connected. It sounds very obvious, but the RTs again will do a lot of this. They'll start saying, okay, well, let's see, make sure everything's connecting, make sure the ETT or the endotracheal tube is not blocked. So they'll suction the patient. They will also disconnect the patient and bag mask ventilate. So attach a bag mask ventilator or a bag mask to the endotracheal tube and start bagging the patient and seeing if the patient is easy or hard to bag. And that may lead to one path or another in terms of thinking about the differential of why they started to deteriorate. And this is a simple differential. Again, it's not much different than any patient who develops hypoxemia. They could have a pneumonia or a ventilator-associated pneumonia, a VAP. They could have mucus plugging that causes worsening hypoxemia and worsening pressures. And a mucus plug is basically a snot. What I think about of a mucus plug is a snot ball that just gets dislodged into one of the airways and causing hypoxemia. And you have to think about pneumothorax. And someone mentioned a question, can you comment on what signs to look out for in barotrauma? So barotrauma will cause a pneumothorax. Things to look out for: decreased air entry, crepitations on physical exam. If there are hemodynamically significant changes such as hypotension, you'll look for hypoxemia. You're gonna make sure the trachea is midline. Those are things you're going to look out for, and obviously get a chest x-ray to make sure there isn't a pneumothorax. So that's why you always get a stat chest x-ray when someone on a ventilator deteriorates. Other causes include bronchoconstriction, spasm, anaphylaxis if there was a recent medication that was delivered, and PE and pulmonary edema. So, and then someone also mentioned, if you think about deterioration, think about alveolar overdistension causing vasoconstriction, gas exchange. So again, this is more for the advanced people in the crowd. If you provide very high pressures and very over distended alveoli, remember the alveoli is like a ball and it's sitting right by blood vessels. And if you over distend the alveoli, you will collapse some of those blood vessels that can lead to both hemodynamic problems as well as gas exchange issues. So sometimes you just have to dial back the pressure. So just keep that in mind. Someone had a good question. If we have a COVID positive patient, is bag mask considered an aerosolizing procedure? Yes, it is considered an aerosolizing procedure. We will get to that when we talk about COVID a bit, but yes, it is considered an aerosolizing procedure. just talking about pressors, again, just basics. I'm not going to go into too much of the pathophys and the of how the pressors work, just because, again, we're going to try to cater to everyone. I'll mention a few of the mainstay pressors. Vasopressors are used for hemodynamic support. So that's to increase blood pressure, especially in someone who's not responding to adequate therapy, which is usually fluids. There are a lot of options: Levophed or norepinephrine, epinephrine, vasopressin or phenylephrine or phenyl are the mainstays that I've used, or that many people use in ICU settings or critical care settings. When in doubt, use Levophed, norepinephrine, especially when you're suspecting septic shock. Most of us will see sepsis causing shock, most of us, in medicine at least. That doesn't necessarily mean you should be blind and go in with kind of visors. You have to keep a broad differential regardless, but majority of us will see sepsis causing shock. And so Levophed is always your go-to in that situation. And in general, Levophed is used for all types of shock as well. So just, and Levophed or norepinephrine is mostly alpha with very little beta 1 and beta 2 activity. And by alpha and beta, those are the receptors that exist on the heart and in the blood vessels. Using analogs of those, or using epinephrine or norepinephrine, those are, when we talk about alpha activity, causes peripheral vasoconstriction. Beta 1 activity actually increases contractility of the heart. And beta 1 activity in the periphery actually causes peripheral vasodilation. So that's just a little bit basics of the pharmacology. Vasopressin actually does not work on any of those receptors. It's actually, vasopressin is an analog to ADH even, and that's actually causes vasoconstriction peripherally. And phenylephrine is a pure alpha agonist, so it causes peripheral vasoconstriction. Epinephrine actually causes both alpha and beta activity as well. In crash situations, so I've been in situations, especially when I was more junior trainee, where someone's hypotensive, I'm giving them fluids, they're not responding. I give them more fluids, they're not responding. And now I'm like, okay, well, we got to start them on pressors. Let's give them Levophed. Well, the problem with that is just a practical point. It takes a little bit of time for the nurses to draw up the Levophed, mix it in a bag, hang the Levophed, and run the Levophed before it even takes effect. Meanwhile, the patient's sitting there with a blood pressure of 70. And so when you see a patient in a very hyperacute situation, you can ask for Levophed. It's just going to take you a bit of time. So if you can't buy that time, there's two main options that I use. Phenylephrine is one of them. Phenyl, like I said, is a pure alpha agonist. And what I do is, again, I usually get a nurse to pre-mix a bag. It's faster though for them to mix a bag of phenyl than it is for Levophed. I don't know why that is. And then I get them to pre-fill a 10 cc syringe with 1,000 micrograms, and that's 100 cc's 100 micrograms per cc. And if you, and I usually deliver anywhere from 1 to 4 cc's. I usually deliver, if they're very hypotensive, I start off with giving them like 2 to 4 cc's of phenylephrine. Just mind you, with phenyl, it does have some possibility of causing rebound bradycardia. So just keep that in mind. So don't use it on a bradycardic patient or someone who has a heart rate that's a little bit lower. But like I said, most of our patients will be tachycardic or have a higher heart rate. So it should be fine in that sense. And then if phenyl, I've been in, this is just a little bit of an aside, I was in a situation where I'm using phenyl and it wasn't working. And I started not freaking out, but I was getting very nervous. And it was a young patient and I'm like, oh man. But somehow I luckily remembered a good trick that my anesthesia colleague taught me, a senior anesthesia resident taught me, is using epinephrine. And many of us in internal medicine may not know this, but I was lucky enough to learn this on my critical care rotation, that you take the crash cart epinephrine, and this is, you have to be very, I want to preface this, very careful when mixing meds. Get nurses to do it for you, please, because they know exactly what they're doing. Sometimes we can miscalculate and things, and that's very dangerous, especially with epinephrine. So with epinephrine, there's a crash cart epinephrine. It's 1 milligram in a 10 cc vial. So that's 0.1 milligrams per cc in that crash cart. Do not give that to a patient. What you can do is take 1 cc of that, put it in a pre-filled 10 cc syringe of normal saline. You're going to empty 1 cc of that normal saline and then fill 0.1 milligrams of that epinephrine in that cc. And that gives you 100, I think I did the math wrong here, maybe, but it gives you, yeah, it gives you 100 micrograms of, I think I did the math wrong. I think it's supposed to be 10 micrograms per cc. Yeah. Or 1 cc of epi. Yeah, that's what I do. So, and you're gonna push 1 cc at a time. Do not push more. Epinephrine can cause a cardiac arrest in the wrong situation. So do not give it willy-nilly. This is, again, if you're very stuck, make sure that you have the right dose. That's very key, to make sure you push only 1 cc at a time. So that's a prelude or a nice segue to talking about shock and hypotension. Just, sorry, I think someone might have a question. Yes, sorry, someone said 10 micrograms per cc of epi. I believe so. I think I made a miscalculation on the slide, so I apologize. And when I send out the slides, I'll correct that. Because that's a huge difference between 10 and 100. So like I said, it's one cc of epinephrine, which is 0.1 micrograms, and then you're going to put, or sorry, 0.1 milligrams, and you're going to put that in a 10 cc syringe. Yeah, exactly, 10 micrograms per ml. Okay, perfect. So so hypotension, shock, they become synonymous. So yeah, I've seen patients. I think the last thing I said before that happened was that some patients will live with a blood pressure that is a bit lower. Some young patients that are relatively healthy and small in terms of their physique may have lower blood pressures. And that doesn't mean they're in shock, but someone that's big or hypertensive and that has a blood pressure of 90 may be in shock. So we have to remember everything's a bit relative, but they have become synonymous. So just remember, shock is actually tissue hyperperfusion, and there's evidence of tissue hyperperfusion with elevated lactates, as well as other end organ damage, whether that be elevated liver enzymes, elevated creatinine or an AKI, as well as other findings. The differential diagnosis, I like this approach to hypotension and shock, is it's a little bit more physiologic. That's why I like it. It's and that relates to the MAP equal the cardiac output times the peripheral vascular resistance. That's what your blood pressure is. So, excuse me. Okay, so starting off with, so this differential is more physiologic. I like it better. We were talking about cardiogenic. This is not supposed to be all encompassing, but it gives you to look out for. In cardiogenic shock, you got to think of an MI, acute valve pathology and arrhythmia, and also you you also have to think about myocarditis. I didn't list that there, but really fulminant myocarditis causing decreased as best as possible. So cardiogenic shock, I hope I'll just repeat myself in case anyone missed it, but really this isn't supposed to be all encompassing, but think of MI, ACS, really big MIs, bad arrhythmias, acute valve pathology. So if someone has a very bad MI, they can get a acute valve rupture, or if they have a dissection, they can get a dissection into their aortic valve causing cardiogenic shock. Those are less common, but just think about that in the back of your mind. And also think about fulminant myocarditis. In fulminant myocarditis, you can get a decreased ejection fraction that leads to hypotension and shock. Then going on to distributive, and like I mentioned, majority of the cases you'll see are sepsis or septic shock. You may encounter anaphylaxis or anaphylactic shock and neurogenic shock, which is only usually seen in patients who've had head trauma or significant traumatic brain injury. And then obstructive shock. So I should mention in distributive shock, you have peripheral vasodilation. So your peripheral vascular resistance drops, and that causes hypotension. And that causes hypotension leading to shock. Your obstructive shock is due to obstruction of blood flow to the rest of the body. And that can cause shock. And so the most common causes of that include pulmonary embolism. You got to think of attention pneumothorax, especially in the ICU. If you start seeing hypotension, acute ventilator deterioration, always think of pneumothorax. And cardiac tamponade, again, that's when fluid accumulates around the lining of the pericardium and the heart that can then obstruct the heart's ability to adequately put out a cardiac output. And then hypovolemic shock, this is all where many of us are aware of from volume depletion. I have seen patients who are quite volume deplete just from decreased PO intake, diarrhea, and vomiting that can cause a bit of hypotension and shock. And then hemorrhagic, our surgery colleagues are probably very well aware of this from significant trauma. But for medicine, we see this in the cases of upper GI bleeds. So very severe upper GI bleeds can cause a hemorrhagic shock. So now coming to one of the biggest components of shock, or one of the most common causes that we see, especially in internal medicine, is sepsis/septic shock. So many of you maybe went through medical school when I did and learned about sepsis or septic shock, and there was a SIRS criteria. And that was kind of the way we defined sepsis. And I remember learning about it, being very well versed in it, and being able to answer questions about the SIRS criteria. And then when I finished medical school, started residency, they had this completely new definition, and so I had to learn everything all over again. So now the definition is a life-threatening organ dysfunction caused by a dysregulated host response to infection. And practically speaking, you're going to use something called the Q-SOFA score, which is the quick sequential organ failure assessment. And you need, and I put that in quotes because that's the criteria, 2 out of 3. Decreased LOC with a GCS less than 13, a resp rate greater than 22, and a PF ratio or a PF ratio less than 300, and hypotension with a systolic blood pressure less than 100. And if you have 2 of these criteria, you fit into the sepsis category. There's a longer SOFA score that includes other aspects of organ perfusion, including bilirubin, platelets, creatinine, and lactate on top of these 3 criteria. But that's, again, most of us won't have that information up front when we see these patients, especially in the emergency department. So that's why they developed the Q-SOFA score. The clinical differential. So any infection can cause sepsis and septic shock. The most common ones are pneumonia and urinary tract infections or pyelonephritis. But don't forget about other infections. Don't forget about cellulitis. And if it's really bad cellulitis, you got to think of, could this be neck fash? You have to think of osteomyelitis, especially in your diabetic patients that have foot ulcers that might have bone involvement, and especially those that haven't been taking care of themselves or haven't been getting adequate foot care may develop significant sepsis from that or septic shock. And then for our surgery colleagues, they're well aware of this. The intra-abdominal infections can obviously lead to sepsis and septic shock. The one you may see on internal medicine that's intra-abdominal related, because most of the surgery surgeons will see this and we won't see this. But one of the ones that I will mention is cholangitis can cause significant septic shock. So that's when there is a stone causing obstruction of the common bile duct that can lead to superimposed bacterial infection and cause sepsis and septic shock. So investigations, I mean, generally going to do the total workup, which includes electrolytes, creatinine, CBC. In the CBC, you may see elevated white count with neutrophilia. You can get anemia, thrombocytosis, or thrombocytopenia when someone's really septic. You can get elevated liver enzymes. Again, that's from tissue hyperperfusion and shock liver. And you should also get blood cultures, urine cultures, sputum, and before antibiotics. And imaging is as indicated. You always should get a chest x-ray for any patient where you suspect sepsis, just to make sure they don't have a pneumonia. And other imaging will be as indicated. Just hold on for 1 second, guys, sorry. Okay. So management of sepsis, septic shock, initial fluid. So there was always this reverse criteria. There was a previous reverse protocol criteria of how to manage sepsis, septic shock. And then we realized many years after that, we may be over resuscitating these patients and to dial back. And so now the guidelines are to fluid resuscitate these patients within 3 hours using 30 cc's per kilogram. Early antibiotic coverage empirically. And again, it depends on what the cause is for the sepsis or the septic shock. And you want to do it again after the cultures. The yield of cultures is much better before antibiotics than after antibiotics. And then we have to consider pressor therapy if the MAP is consistently below 65 after fluid resuscitation. And typically I say between 2 to 3 liters or 2.5 to 3 liters, you have to, and their MAP is still less than 65, you should probably start heading towards the ICU and requiring Levophed. Some people, again, it's site dependent, will be more aggressive about giving more fluids before going to the ICU. Again, I'm of the opinion that if they've gotten 2 to 3 liters of fluid and their MAP is still below 65, that they should probably be on some pressor therapy, at least for a time-limited duration. One thing I'll mention is don't forget about source control and call your IR or surgery colleagues as appropriate. So abscesses need to be drained. You can give antibiotics all you want. It's not necessarily going to cure that abscess. Again, it depends on where the source is. If it's a lung source and they have an empyema, which is an infection of the pleural space, you need to call thoracic surgery. If there's neck fascia, you should call plastics immediately, things like that. And again, that will depend on the source of infection. One thing I didn't mention in the slide that I'll mention is you also want to follow their laboratory work and end organ function. You want to make sure you're following their lactate and make sure that's normalizing after your resuscitative efforts. You want to make sure that their urine output, especially if in their ICU, they should be monitoring urine output in the ICU. In the ward, you may not be monitoring this, but you should have a Foley in the ICU and monitor urine output every hour, and it should be greater than 0.5 cc's per kilogram per hour. And also the PF ratio, especially in those are the septic shock patients that are intubated. You want to maintain a PF ratio greater than 300. So you want to make sure you're not over resuscitating them to the point that they're going into pulmonary edema. So COVID-19. So this is not meant to scare anyone. This slide is just for interest's sake. It was someone who put together a one pager on COVID-19. We're not going to go through all of this. Obviously, we won't have that much time, but it's a little bit of a reference for those who are interested and can refer to it afterwards. COVID-19, just briefly, is a RNA virus that has an ACE2 receptor on its surface. This allows it to enter the epithelial cells of the lung, as well as other cells around the body that have the ACE receptor. This allows it then to use its RNA to replicate and produce other viruses and then spread throughout the body. Things to watch out for in COVID-19 symptoms-wise are cough, obviously fever, dyspnea, viral URTI symptoms, runny nose, congestion. Look out for GI symptoms like abdominal pain, diarrhea. And these occur with various frequencies in terms of the percentage of patients that will have it. Right now, I think because we're living in such scary times, we have to be very vigilant and be very cognizant that if a patient has certain symptoms, can it be related to COVID? Now, that being said, not everything is COVID-19, so we have to keep our broad differential as well. Most commonly, you'll see cough and fevers in these patients, as well as dyspnea, especially in the patients that are quite ill. A little bit about the clinical course. The clinical course, patients can be asymptomatic, as you know, for 4 to 5 days after exposure. And then, and as you know, the incubation period is anywhere from 4 to 14 days. And some people and some studies have actually are indicating that it may be even a bit longer than 14 days. Excuse me. And after the asymptomatic period, the patient usually requires hospitalization by day 7 or 8 post-exposure. That's when they start developing maybe some hypoxemia or have some significant chest X-ray findings and may require hospitalization. And then a lot of the patients, some studies have shown that require ICU admission by day 10, especially if they're heading south. 5% of patients require ICU admission, and this will vary from jurisdiction to jurisdiction, but all the data we have collected thus far shows a significant proportion does require ICU admission. And the fatality or the mortality rate, as you may be aware, right now, I believe it's closer to 3 to 4%. Again, this is very variable across the board. Some countries like Italy, it's almost up to 9%, I believe. And so in certain areas, it's higher. In other areas, it's lower. Right now in Canada, I believe the mortality rate is only 1.5%, but I anticipate that it will go up slightly, given that the number of cases are coming in and rising. Labs, things to watch out for. Again, you're going to do your typical labs. You're going to watch out for leukopenia, actually. And viral infections can generally cause leukopenia, but they can also cause lymphopenia. And COVID-19 has shown to do that. It can cause an AKI and liver enzyme elevation. So be mindful if you have lymphopenia and liver enzyme elevation in someone who has viral symptoms, think of COVID-19. And then other things that have shown to be elevated include D-dimer and ferritin. I'm not sure why those were done initially in those patients, but they've actually shown to portend a poor prognosis. The imaging, and this is an imaging example of COVID X-ray, shows bilateral peripheral opacities. Some patients will have interstitial opacities. There will be ground glass opacities on CT chest, and there have been reported cases of crazy paving as well, which is just an imaging finding and described here. And on POCUS, if people are experienced in point of care ultrasound, they see B lines and pleural thickening. One note, I would say, if you have a patient with COVID-19, a chest X-ray is more than sufficient. It doesn't necessarily, is not sensitive enough to rule out COVID. There's reports that CTs are more sensitive, but I would not CT a patient to determine if they have COVID. I would just do a chest X-ray. If they get worse, or if you're considering another diagnosis like empyema or a PE, then that's a different reason to do a chest CT. So remember, member not to just be like, oh, this patient, I don't know if this patient has COVID, let me just put them in the CT scanner, because that's not an appropriate use of resources. And I believe many of the radiology societies have come out with statements indicating that. This is just a slide excuse me, to indicate things that indicate poor prognosis. So things like, obviously, age has been shown to have worse prognosis or poor clinical outcomes. As we know, patients above the age of 80 from the recent studies have shown 15% mortality rate. So it's quite significant if an 80-year-old gets COVID-19. People with cardiovascular disease, underlying lung disease are obviously at a higher risk. And I already mentioned elevated D-dimer, ferritin have shown to be worse outcomes. So the management of these patients, how do we manage these patients? To be honest, it's actually very similar to managing any patient admitted with an upper or lower respiratory infection from a virus. So empirically, when you say these patients that emerge, you're going to send the full workup. You're going to do CBC lights, creatinine. You're going to do blood cultures, potentially, especially if they're very sick. You're going to do an MP swab. You're going to do sputum. You're going to do sputum cultures if possible, if they're producing sputum, and you're going to send off for liver enzymes and so forth. You'll send the ferritin, D-dimer, CRP. Again, this may not change your management. It may just indicate how bad the case may be. And then obviously you're going to get a chest x-ray. You're going to isolate anyone you have any suspicion for. Anyone that gets swabbed has to be isolated. That's usually an IPAC rule for the hospital. But if you have suspicion, you should, and you're admitting the patient, you should swab them, put them under isolation for COVID. The personal protective equipment right now is, and I believe it'll continue to be this, is face mask, or a regular surgical mask, a face shield, gown, and gloves. Patients should be on droplet plus contact precautions. This has not changed. The transmission of COVID is droplet and contact, meaning someone has to cough or sneeze, and if you're within 2 meters, that's how it spreads. This also spreads from if it's on a surface and someone touches it and then touches their eyes or mucous membranes, they can get COVID from that. That's fomite transmission. There is possible transmission via fecal oral routes, but that is unclear at this moment in time. The data is unclear whether that actually happens. But if you take the droplet plus contact precautions necessary, that should be adequate. The airborne precautions should be reserved for those who are doing aerosolizing procedures. And sorry, I was just checking if I had a slide on that. I don't, but for aerosolizing procedures, basically what that means is if you're intubating, doing any type of bronchoscopy, which most patients won't require with COVID-19, but if you have a COVID-19 patient and for some reason there's a bronchoscopy being done, it should be done under airborne precautions. And then if you're bag masking, if you're doing NIV, those are all aerosolizing procedures. High flow nasal cannula has shown to aerosolize the virus. But because many of these things are aerosolizing, many of them won't be done. And so I'm just going on to the next slide, and it mentions avoiding NIV. So you should not, if you have a COVID patient, you will, most hospitals are doing this, they will not do BIPAP on that patient. They will not do CPAP on that patient, although you shouldn't be doing CPAP anyways. They will go, if they have increasing oxygen requirements after face mask, they will just intubate the patient. And that should be done under airborne precautions, minimizing the number of people in the room. The most experienced person doing the most experienced intubator should be intubating the patient, and they should take the appropriate precautions. If we have questions on personal protective equipment, we can address that a bit later. I just want to move on just because there's a lot still to cover. The management is largely supportive. So you're going to admit, if you're admitting the patient, you're going to admit them. If you have high suspicion of superimposed bacterial infection, such as a consolidation on the chest x-ray or bilateral airspace opacities, you may cover them with antibiotics, and that will be a clinician-driven judgment call as well. And I would cover them then for a community, as well as a community-acquired pneumonia. With ceftriaxone plus minus azithromycin. You'll cover them empirically for the flu. There's no harm in giving Tamiflu, but I would discontinue Tamiflu if their influenza swab was negative. You're going to monitor them. You're going to give them oxygen therapy as required. You're going to monitor for any end organ damage or failure. And like I mentioned, these patients will, small subset of patients will require ICU admission and mechanical ventilation because of ARDS. And as far as I'm aware, the ICUs across the city are still treating these patients with COVID-19 and ARDS as they treat all their patients with ARDS. There's no changes as of yet. These are things that are in flux though, and they could change. But for those who may be in the ICU, just to keep that in mind, the management of ARDS was still the same. Treatments. So there's lots and lots of discussion on Facebook groups and chat groups about treatments, and I have a lot of friends in ID. There are no treatments that have shown any benefit in COVID-19 as thus far. There is some data, and there was a recent study that used Plaquenil, and I'm not going to go too much into the studies, but that show Plaquenil may be used in treatment of COVID. The study that was done really only showed that viral shedding was less in patients that were treated with Plaquenil, and they excluded patients that were worsened on Plaquenil therapy in their analysis, and they did not show any mortality data on these patients or outcomes on these patients. There was a recent study on leponavir-ritonavir, which is a protease inhibitor used in HIV and had in vitro activity. A lot of the studies actually that are done show in vitro activity of these agents, but clinical evidence is lacking. And so there was actually a recent NEJM study that came out, I think a few days ago, that showed actually, it was a small study, only 200 patients, that showed no benefit of leponavir-ritonavir. But again, the flip side of that is it was probably underpowered. And there's lots of talk of tocilizumab, which is an anti-IL-6 inhibitor. These patients with COVID-19 were found to have elevated IL-6 levels, and therefore the group in China have been trying this, and apparently with success. It was a small group, there was no control group, but they may be considered. One recommendation I would say that has been supported probably universally is do not treat these patients with corticosteroids. It has shown to possibly worsen outcomes or at least not have any benefit, unless there's a compelling other indication such as COPD or asthma exacerbation. This is just a table for reference purposes. I'm not going to go through it. Again, just some of the regimens. It will vary from jurisdiction to jurisdiction. Nazia came up with this table, so I'm not sure exactly where she got this from. But again, I would consult ID. That's why it's written there, consult ID, if it's a severe case or if you think they warrant treatment or if you want an opinion about treatment. There's a lot of questions regarding ACE inhibitors, ARBs, ARNIs, which are your angiotensin neprilysin inhibitors, such as Entresto, which are used in heart failure. Also, there's a lot of talk about NSAIDs and whether they worsen outcomes and this has to do with the pathophysiology and the microbiology of the virus itself. I would say right now, a lot of groups have come out very quickly with position statements, which is very helpful. The CCS, as well as which is the Canadian Cardiovascular Society, as well as the European Society for Cardiology, came out with statements saying, basically, I'll summarize it, do not stop ACE inhibitors or ARBs in patients with COVID. That includes if they prophylactically. I've been seeing people ask, should we prophylactically stop patients' ACE, ARBs, or ARNIs? And the answer is definitely not. Continue therapy. If they get COVID-19, still continue their ACE and ARB and ARNI because they're at risk for exacerbating underlying condition as well. The only reason I would stop an ACE, ARB, or ARNI is if they have another reason to stop it, which would not differ from my regular management, meaning if they have an AKI or hypotension, hyperkalemia, those are reasons to hold those medications, not COVID-19. And then NSAIDs, a lot of talk about NSAIDs. My position is, and I think most people will agree with me on this, is if there's an indication for an NSAID, use it. Meaning if they have a stroke or MI, use aspirin. If they have pericarditis, you have to use your NSAIDs. If there is no compelling reason to use NSAIDs, meaning if you're using an NSAID for fever or pain, I would generally avoid it in those circumstances. And that, to be honest, doesn't really differ from what I do right now. Most of my patients I can't use NSAIDs on because they have a history of heart disease or chronic kidney disease. And so I try to avoid NSAIDs in general for that reason. But with patients with COVID-19, I also try to avoid it if there's no other compelling reason. And when I mean compelling reason is, your usual reasons to use NSAIDs, such as stroke, MI, pericarditis. There's other inflammatory arthritises you can use it for as well. So that's that statement. Delirium. Again, we're kind of running out of time, so I'll try to quickly go through. I don't think we have much left, but I'm going to try to quickly cover the next few topics. Many of you may be well versed with delirium. I know there's a lot of psychiatrists, and they are very well versed with this topic as well. So I'm just going to blast through this, but the criteria is inattention and acute onset plus disorganized thinking or altered level of consciousness. And by altered level of consciousness, that doesn't necessarily mean decreased level of consciousness. It can also be hyperactive. So just keep that in mind.
Hamzah, I'm just giving you a 5-minute warning.
Okay, thank you. This is the differential for acute delirium, and it basically is the DIMS mnemonic. Again, I'm not going to go very hyper in depth into this. Always consider drugs, especially sedative agents. Always consider infection, metabolic causes such as hyponatremia or hypercalcemia. Think about high CO2 levels and liver enzyme abnormalities. And don't forget structural causes, not just structural causes in the head. So you're going to get your CT head to rule out stroke or anything like that. But also think about structural causes outside of the brain, such as urinary retention and constipation. Imagine if you you couldn't pee for several hours and you had several cc's, up to a liter of urine in your bladder, you probably go crazy too. So just keep that in mind. The workup for delirium, you want to complete your DIMS mnemonic. So you're going to send a broad panel of blood work, including electrolytes, extended electrolytes, creatinine, liver enzymes. To complete the workup, I would also send a TSH and vitamin B12 level. I would send cultures if I suspect a underlying infection. CT head should be done, a tox screen as indicated. One thing I would say about cultures is a positive urine analysis with delirium does not necessarily equal a urinary tract infection. The my ID colleagues will be very aggressive about not giving these patients antibiotics. And I know the other flip side is, well, if we don't have a better explanation for their delirium, we should treat it with antibiotics. And I think we should just try to, take both sides of the argument. And if there's a positive urine culture, they're not getting better. And if they mount on some other manifestation other than delirium, then I think that's a very good reason to give antibiotics. But, or if they're not improving, that may be another indication. But just keep those both arguments in mind when treating patients. We want to be stewards about antibiotics, but at the same time, we want to make sure that we're treating our patients appropriately. The management of delirium. So delirium is not a diagnosis, it's a symptom. There's an underlying cause. Treat that underlying cause, whether it be, constipation, urinary retention, infection, whatever it may be, restore their electrolytes. And then a lot of delirium management is basically non-pharmacologic. Make sure they have their hearing aids, glasses, make sure they're being reoriented by family, make sure they're sleeping at night and up during the day, not the opposite. Make sure they're up in a chair. All our patients are lying in bed. They should be sitting, not lying in bed all day, which causes them to go to sleep. And manage their medications and eliminate medications that are unnecessary. Electrolyte derangements, I think Bilal gave me the 5-minute warning, so this is the last topic. I'm going to blast through this. Hyperkalemia oftentimes is asymptomatic, but don't forget to ask about symptoms. These are kind of some of the causes of hyperkalemia. Think about drugs, which are listed here, as well as non-medication causes, most commonly renal failure. And the management of hyperkalemia will depend on how severe the potassium is and whether there are any ECG changes. I usually give patients with a potassium above 6, whether there's ECG changes or not, I usually give them calcium gluconate, which is to stabilize the cardiac membrane, and then I treat their underlying hyperkalemia. One thing to note: shifting does not treat hyperkalemia. It just causes the potassium to go inside the cells. If you wait long enough, the potassium will be released again. So make sure you give them an agent that will cause increased excretion of the potassium, whether that's Lasix, whether that's laxatives, or even fluids. Again, I'm sorry we're running out of time. We can maybe talk about this at another session. Shifting, just to be careful if you're giving insulin, it's 10 units, but give it after you give the dextrose. So you want to give the 50, it's not 50 amps, it should be dextrose 50 water, 1 amp, and then you're going to give insulin. How can we have a talk on internal medicine and not mention hyponatremia? Oftentimes is asymptomatic. There will be some neurologic manifestations. The scary one is seizures. This is the differential. Again, I don't think we have time to cover the full differential right now, so I'm just going to mention that the key is the urine sodium. If it's less than 20, you have to think of hypovolemic or hypervolemic, and to differentiate between those two, you just do a physical exam. If they're volume overloaded, it's hypervolemic. If they're not, they're hypo. If the urinal sodium is above 20, then you have to think of hypothyroidism, adrenal insufficiency, and SIADH. And this is just a differential of what can cause SIADH. Unfortunately, again, I think we're running out of time, so I'll just skip that, but we can look this over. The key is the treatment. Stop. In hyponatremia, don't do anything first. Just stop and think. And
Sorry, Hamzah, in the interest of time, we're probably gonna have to wrap
sure.
up there.
Yeah, that's fine.
Sorry to interrupt you.
That's okay.
Thank you everybody for joining us today. I hopefully that was helpful for you guys. Just a reminder, Hamzah, sorry, can you just go back to the MMAC slide?
Oh yes, sir. This one?
Yep, that one. So that's our website there. If you want to see more programs like this, feel free to reach out to us, and we will do our best to help out where we can. And we're just going to log off now just so we can get the next session going. Thank you, guys.
Thank you, everyone.
And great chat. Great talk, Hamzah.
Thanks.